Dr. Jacobs touched upon different unique aspects of CT imaging and used in cardiovascular applications, and focused mainly on using CT for looking at the coronary arteries. She showed some excellent examples showing that with cardiac CT imaging, we can get great visualization of the coronary arteries, both for diagnosing anomalous coronary artery origins, such as this example of a single left coronary system giving rise to both the left and right arteries, and also its utility in diagnosing coronary artery disease and characterizing plaque. However, there's much more to the heart than just the coronary arteries. And Dr. Jacobs touched a little bit on other cardiovascular applications, and I'm going to go just a bit more further into detail on these other areas of looking at the heart structure. Just a couple of notes on the technical aspects, which is we've already gone over, but with cardiac imaging, we definitely need high spatial resolution since several of the cardiac structures are extremely small, valve motion, such as valve leaflets as well as the coronary arteries. In addition, because presumably the heart's moving in our patients, we need high temporal resolution, both to minimize motion artifact as well as to assess cardiac motion. As a result, we try to synchronize our image acquisition to the heartbeat or the heart rhythm, and we do this in the form of ECG gating. In addition, we can do multi-phase reconstruction to get an assessment of cardiac motion. Why do we gate the heart? As I mentioned, because of cardiac motion, with a conventional ungated CT imaging, we get a lot of motion or pulsation artifact, especially seen here in the ascending aorta, in which pretty sure there's not a dissection there, but we can't be totally 100% sure. When we gate to the cardiac rhythm and reconstruct during a pre-specified phase of the cardiac cycle, we get rid of this cardiac motion, and we know for sure that there is no dissection in this ascending aorta. Multi-phase reconstruction just simply means reconstructing at specified intervals throughout the cardiac cycle and then looping the intervals together, looping the data sets together rather, to create an image cine loop that we can use to look at cardiac motion and function. Now, the heart doesn't lie along the traditional axial, coronal, and sagittal planes of the body. Instead, the heart has its own diagnostic axes. And for looking at cardiac disease, it's often helpful to orient our imaging planes along these cardiac axes, including the horizontal long axis plane. In this view, we see the four chambers of the heart: the anterior trabeculated right ventricular chamber, the associated right atrial chamber, the more thick-walled left ventricular chamber, and left atrial chamber. The wall segments include the interatrial septum, the interventricular septum, or septal wall, the lateral wall of the left ventricle, and the apex, as well as the right ventricular free wall. We also get a view of the atrioventricular valves, including the left-sided mitral valve and the right-sided tricuspid valve. And in addition, we can see the thin pericardium that surrounds the entire heart. Moving on to the vertical long axis view, or otherwise known as two-chamber view, we have visualization of the left ventricular chamber, the left atrial chamber, some vascular structures, including the pulmonary arteries and coronary sinus. The ventricular walls here are the anterior wall, the inferior wall, and the apex. And again, we see the left-sided atrial ventricular mitral valve, and the pericardium again, which surrounds the heart. If we then orient orthogonal to our two long axis slices, we can get a nice short axis view of the heart, otherwise called the donut view because the left ventricle looks like a donut. We have the anterior right ventricular chamber, posterior left ventricular chamber, and the wall segments here include the anterior wall, the lateral wall, the inferior wall, the interventricular septal wall, and the right ventricular free wall. And again, we have the pericardium, which surrounds the heart. Because we want to look at the cardiac images along the cardiac planes, we do a lot of post-processing of our data sets, oftentimes in MPR or MIP projections. In addition, as was shown earlier, we can use volume-rendered imaging to get a more 3D appearance of the heart to look at anatomy. And this is just an example of how we arrive at our cardiac planes. So, slice through until I find an axial plane that mimics my four-chamber view. Then I'll rotate an axis along this four-chamber view to get our two-chamber view. And then if you follow into this plane, what I'm doing now is orienting to the short axis view of the heart, which then allows me to slice up and down through the short axis of the heart and better orient to get along the diagnostic axes. And then by going through the heart chambers in the short axis slices, it gives me a good view of the ventricular walls, right side of the heart, left side of the heart, as well as a view of the basal mitral leaflets and aortic valve leaflets. And in this particular case, this patient has a calcified apical aneurysm seen here along the anterior septal wall. In addition, there's some noted wall thinning here along the inferior lateral aspect of the left ventricular wall. And in general, the heart looks a little bit dilated. And this is just a 3D volume rendered image, again showing this calcified apex. Dr. Jacobs went over the scanning protocol that we use for coronary artery imaging. Our general cardiac protocol depends upon what we're trying to image, but in general, we do try to reduce the heart rate to less than 75 beats per minute, and we'll give beta blockers as needed, but also to promote regularity of the RR intervals. In general, we do like to give contrast so that we can visualize the ventricular chambers as well as distinguish the walls of the heart. And depending upon the the area of interest, the amount of contrast and timing of the contrast will be varied. Several different things can degrade our image quality, including motion artifacts related to heart rhythms or respiratory motion, or just improper contrast timing. And we see that motion artifacts tend to affect our smaller, more mobile structures as compared to larger structures such as the aorta or pericardium. So looking at the coronary arteries or in valvular disease, we see that we're much more affected by motion artifact. Moving on to some clinical applications, Dr. Jacobs has already shown you the excellent use of cardiac CT imaging for coronary artery assessment. I'm going to focus on these other cardiovascular applications, starting with the myocardial disease. We've already seen a couple slides showing the utility of CT imaging looking at myocardial infarct areas. We can also use it for restrictive cardiomyopathy, as well as looking at for ventricular dysplasia. The scan protocols are in the disc that you'll be getting, so I'm going to just kind of skip through that. This is a 40-year-old gentleman who had significant LAD disease, which was known in the past, and we see here on coronary imaging calcified, non-calcified plaque within the LAD. When we look at the myocardium and ventricular chamber, we see that there's preserved wall thickness throughout the heart, except for the apical portion of the heart noted here, where there is significant wall thinning as well as a ventricular mass, which is felt to be a thrombus in an associated aneurysm. This is another patient, a 60-year-old gentleman, also with noted significant LAD disease, calcified plaque seen here, as well as non-calcified plaque with significant luminal narrowing. When we look at the ventricular myocardium, again, we see that there is preserved myocardial thickness, but this is limited to the basal anterior wall and the inferior wall, and we see the mid and distal portions of the anterior wall, there is significant wall thinning, noted here as well as here. In addition, there's a significant perfusion defect noted in this wall. And when we look at our motion images, we can see that there's severe hypokinesis of this anterior wall, and this is consistent with a myocardial infarction in this territory. Moving on to other forms of myocardial disease. This is a patient with a strong family history of hypertrophic cardiomyopathy, and he shows the same characteristics as his family members, this severely thickened hypertrophied ventricular wall limited to the septum. This is another patient also with a diagnosis of hypertrophic cardiomyopathy, but this time limited to the apical wall and the so-called spade-shaped heart. This is another form of a restrictive cardiomyopathy in which there is a defect in embryogenesis where the left ventricular wall fails to compact. And we see that the septal wall here of the left ventricle shows the same trabeculated kind of pattern that we see in the normally see limited to the right ventricular wall. We also see this in the inferior wall, and this was also shown on MRI imaging. This was a patient who was claustrophobic, and there was a question of arrhythmogenic RV dysplasia. Patient was noted to have a dilated RV on echo imaging. We see here that there is a large dilated right-sided chambers, and the right ventricular free wall, the myocardium is very thin and has sort of a scalloped appearance. In addition, we see that there is dark areas within the ventricular wall consistent with fatty infiltration, consistent with arrhythmogenic RV dysplasia. And again, we can get, using our multi-phase reconstruction, we can get an assessment of function, both regional and global function. And in our laboratory here, we've correlated our global volume and ejection fraction as determined by CT imaging with echo and SPECT imaging and showed a good correlation. Moving on now to pericardial diseases. Normal pericardium is a very thin layer that surrounds the heart. It's normally less than 3 millimeters thick. We're often asked to look at the pericardium for the evaluation of pericardial diseases, in particular constrictive pericarditis. And while CT imaging can give us a great anatomic view of the pericardium, there is very limited hemodynamic information. This is an example from a patient who was having heart failure symptoms and was noted to have a thick, nearly circumferential rind of pericardial calcification, as well as there is some tubular deformation of the right and left ventricles, seen here on the four-chamber view, consistent with constrictive pericarditis. This is a patient who underwent pacemaker placement and had a follow-up chest X-ray a day later and was noted to have an abnormal right heart border contour. CT imaging demonstrated a large pericardial effusion, seen here. And we can see that the pacemaker wire has perforated through the right atrial wall. This is a patient who was actually undergoing CT imaging to look at his bypass grafts after having surgery and complaining of chest pain. Bypass grafts were all found to be patent. However, when we looked at the myocardium and pericardium in this patient, we see that there is significant thickening of both the visceral and parietal pericardial layers. And this patient was felt to have acute pericarditis. Moving on to cardiac masses. Although we have limited assessment of tissue properties with CT imaging, unlike MR imaging, we can get information about the location and extent of any masses, vascular involvement, and assess for lymphadenopathy and for other primaries or metastases. This is a patient who had was presenting with heart failure symptoms, was noted to have a right atrial mass on echocardiography with some mobile components, as we can see here. When they looked on echocardiography at the IVC, which is relatively free of disease, and they would only get a hint of the SVC, but it appeared to be originating from the SVC. Patient underwent CT scanning, and here we see a large heterogeneous mass completely filling the SVC in this patient. Patient underwent MRI imaging for further tissue characterization, and based on its T1, T2 characteristics, this was felt to be consistent with a malignancy as opposed to thrombus. Patient underwent surgical resection and pathology was found to have a synovial cell sarcoma. This is another patient who was found on echo imaging to have a right atrial mass prolapsing into the right ventricular chamber. Based on echo characteristics, there was heterogeneity of this mass, and there was a suggestion of malignancy. CT imaging demonstrated that this patient actually had a catheter in his SVC extending into his right atrium, and that this heterogeneous mass was actually attached to the catheter and appeared to be more consistent with an infected thrombus, which was eventually resected. This was a patient who presented with an asymptomatic patient presenting with an intramyocardial mass, initially seen on echo imaging, underwent tissue characterization with MR, and we see that there is enhancement of this mass, noted especially on delayed imaging, but there's a dark area in the center of this mass. Patient underwent further imaging with CT, and we see like this dark mass is mainly calcification within this area. It was felt to probably represent a fibroma, which is often known to calcify. Patient had resection of this intramyocardial mass, which was proven to be a fibroma. And this is another patient with a left atrial mass who underwent CT imaging to better delineate the attachment site of this mass. This was found to be a left atrial myxoma with just an unusual attachment site, since myxoma is often attached to the septum. This one was attaching to the left atrial free wall. And there was no involvement of the mitral valve leaflets. And this patient had a history of a sarcoma, was found to have a large pericardial mass that we see here. There did not seem to be any involvement of the ventricular myocardium. However, when we looked at the coronary arteries, we see that the left anterior descending, shown here, actually fed into the mass, sort of being parasitized by the mass. And this turned out to be a recurrent pericardial sarcoma. Moving on to congenital heart disease and congenital vascular disease. We commonly will use MRI to assess congenital heart disease, but we've been moving towards more and more CT imaging. There are advantages to CT imaging for looking at congenital heart disease. It's a fairly quick examination compared to corresponding MR or echo. In addition, we get excellent 3D spatial resolution, and we can usually perform this test without sedation. However, there are disadvantages, including radiation exposure, the use of contrast requiring intravenous access, and in addition, there is limited functional information because of the limited temporal resolution of CT imaging. This is actually an older patient who underwent a PE protocol to preoperatively for pulmonary embolectomy, and we see there is a clot here in the right pulmonary artery. However, when we orient it along the cardiac planes, we see this incidental finding of an ASD actually was found to be a sinus venosus ASD, and there was also partial anomalous pulmonary venous return. This is another patient who was noted to have a dilated coronary sinus, noted here. And we commonly think, when we see this in an asymptomatic patient, we wonder about a persistent left superior vena cava, which this patient did not have. Instead, when we looked, the right-sided chambers appeared a little bit dilated, and we see that the coronary sinus actually connects with both the right atrium and the left atrium. And this is an unroofed coronary sinus ASD. This is a patient who has known tricuspid atresia, had undergone a modified Fontan procedure as a child, and was undergoing follow-up imaging for assessment of anatomy and looking at the pulmonary arteries. Here we see the SVC draining into the right atrium, which the main pulmonary artery was attached to. And then we get a view of the right and left pulmonary arteries. And we see here in this patient there's a mild but left pulmonary artery stenosis. This is another patient with tricuspid atresia who had undergone a Fontan procedure, and we can see the IVC to left pulmonary artery graft, both noted here as well as in the MPR image on the left, on your right. And we see that there's a left-sided as well as right-sided SVC, with the right-sided system draining into the right pulmonary artery and the left-sided system draining into the left pulmonary artery. And we also got a view of the internal anatomy, cardiac chambers, and we see that the right-sided chamber is small. There is a VSD noted as well, since this is a tricuspid atresia patient. Now I'm shifting to vascular abnormalities. There's limited, again, I mentioned hemodynamic information with CT, but we can get a good look at anatomy. And we see this coarctation here. And we can also look for collateral flow, although in children, it's less likely that you'll see collateral flow. This is a patient with question of a vascular ring and was found to have persistent right-sided arch, giving a double aortic arch appearance. Moving on to using CT imaging for vascular assessment, both for looking at the aorta as well as pulmonary arteries, pulmonary veins, and systemic veins. So we see in this example of a patient with an ascending aortic aneurysm with ECG gating, we have clear delineation of the ascending aortic walls, and we can see for sure that there is no dissection with this aneurysm. This is actually a non-gated image obtained from another institution where they looked at the images in the axial planes and completely missed this left sinus of Valsalva aneurysm delineated here. When we oriented more along the plane of the aortic axis, then we can see this sinus of Valsalva aneurysm. And this is a patient with a dissection. We see the dissection flap, associated hematoma. And when we slice through at different levels of the heart, again, we see the dissection flap, associated hematoma, and we see the left coronary artery as it originates going into this diseased area and being affected. This patient actually had bypass grafts, and we see here that the bypass graft actually was intact and not affected by the dissection. That was a communicating dissection. This is a non-communicating dissection, otherwise known as intramural hematoma, where instead of an actual dissection flap, we see crescentic thickening of the aortic wall. And as endovascular procedures become more and more common, we're starting to get a view of aortic stent grafts. The patient on your left had an aortic stent graft placed for coarctation. The one on the right has an abdominal stent graft. And looking for complications of stent grafts, we see that there is a pseudoaneurysm formation with the stent graft on your right with associated hematoma. We've been using cardiac CT imaging to help our EP colleagues in cardiology for their atrial fibrillation patients undergoing radiofrequency ablation. We provide a roadmap for them during their procedure, and also we can assess for potential procedural complications. This is just an example showing how the CT image data is synchronized with the electrophysiology data, and it allows them to manipulate their catheter with a roadmap, making their procedure much quicker, actually. And we can assess pre-procedural if there are going to be any problems with the procedure. This is a patient with a left atrial appendage thrombus, which puts this patient at high risk for stroke. And we can assess for post-procedural complications, such as pulmonary vein stenosis, as seen here. And this is a left lower pulmonary vein. And then just a word about valvular heart disease. I think Dr. Jacobs may have shown you a little bit of some of these images, but we can use, with our functional imaging, we can visually assess the aortic valve and mitral valve, as well as the tricuspid, depending upon how your contrast injection is timed. In this particular case, we have a patient who has a bicuspid aortic valve with fusion of the left and right coronary cusps. The leaflets actually open fairly well. There's no significant stenosis in this case, as opposed to this case where there's significant calcification of the valve leaflets, limited opening of one of the leaflets noted here. And when we look on short axis, we see that the valve area, the effective aortic valve area, is significantly reduced. And this is in contrast to a patient with aortic regurgitation, where we see there is incomplete coaptation of the leaflets here on this long axis view of the valve. And when we look at the valve in short axis, we see this little hole where there's incomplete coaptation of the valve leaflets. This is a patient, this is an older case I have, a patient with tilting disc prosthetic aortic valve. And when we looked along the aortic valve planes, we see there's actual dehiscence of the valve. And this is just to show you that we can get a good view of the mitral valve apparatus and look for mitral valve disease as well. This is a normal mitral valve. So where are we headed with CT imaging? We've probably heard of the triple protocol, or where we do combined aortic, coronary, as well as pulmonary artery imaging. We haven't been pursuing that in our institution just because our scanner is not in the ED, but that's something we're hearing more and more about. We're going to hear more and more about functional analysis, both regional and global, as well as perfusion by CT. And we're moving more and more into combined multimodality imaging for a cardiac assessment. This is just, I had shown you earlier a case showing a significant perfusion defect. We usually don't image later in our patients, but this is just to show in an animal model, early dark perfusion defect followed by delayed imaging showing enhancement, similar to what we see in MRI, delayed enhancement imaging, and corresponding to area of infarct. So it might be useful in viability imaging as well. And in our lab, we've been working with fusing our images. This is actually a SPECT and CT, sorry, a SPECT image overlay on top of a CT image, where we can use the CT to look at coronary artery anatomy and using the SPECT images for our perfusion information. And this is actually a PET CT image with fusion to look for areas of inflammation in this patient with Takayasu's arteritis.